I would now like to take the privilege of introducing somebody who is the chief guest for this inaugural session, and possibly where I am today as a program coordinator for such a prestigious antimicrobial stewardship program on behalf of CAHO in the entire country. It wouldn't have been possible if I wouldn't have met this person at a young age of mine in 1995. My relationship goes with Professor Dilip Mathai since then, 1995. That time he was the professor of medicine of CMCH Vellore. More than 2 decades he has spent in CMCH Vellore as professor of medicine and infectious disease. He himself developed the infectious disease in this country. He laid the foundation stone of ID specialty in this country. He is the founder father of ID specialty in this country. Presently, he is the Dean and Professor of Medicine and Head of Adult Infectious Disease of Apollo Institute of Medical Science and Research, Apollo Health City, Hyderabad. And it's my fortune. I am really overwhelmed in joy that Sir could be able to come over here, bless us, and be the chief guest of this antimicrobial stewardship program inauguration. Dr. Dilip Mathai, sir, please.
Thank you so much, Dr. Sankar Sengupta, for inviting me to participate, and Lallu, colleague of mine when I was at CMC Vellore. I really didn't know that it was a formal occasion where I had to talk. They just told me, come along and be a part of this movement. So I said, okay, I would love to be part of this movement on antimicrobial stewardship program. I really welcome the CAHO having taken this initiative to develop this. It has been my dream as well to have an e-learning tool for hospital stewardship. And this and also ensure certification either through CAHO or via NABH. So if it is, I have not seen this certificate program or this e-learning tool, but if it is something that can be upgraded, and then it would be excellent. The second thing that I really wanted to say was, do you have a survey? Now, I fully understand that surveys after surveys have been done to show that AMSP does not exist. Yes, I do understand. But so the survey, really I want to know if there is any knowledge gap. What is it that a hospital wants? I know what my medical college needs or what my medical college should do. But we need to understand the knowledge gaps in AMSP. Either CEFIT can take the leadership, Pfizer is taking the leadership as well. Somebody or CAHO can take the leadership to understand the knowledge gaps, and then you can make a good, impactful learning program. The third thing that I wanted to say was about AMSP as a measure of quality improvement. That is where the main role of CAHO should come in. So how do I bring in AMSP as a quality improvement or tool? If CAHO can develop a good program for that, so we have got, structural indicators. Each hospital should be proud to present their structural indicators. What should be their structural indicators? Dilip, do you have a guideline for your hospital? Yes, we have. Very good. Now, do you have any kind of formal education for your staff? Yes, we have. Give me points, whatever it is. Second thing that I would like to do is, how do you do this process measure? This has always been compliance. I take only very few things. I personally supervise the compliance of surgical prophylaxis, because 40% of all antibiotics used is in surgical prophylaxis. And the remainder 40% is really in the outpatient. So this weekend I am giving a talk to the Tamil Nadu Association of Physicians on AMSP for the outpatient physician. And in the hospital, if you focus on surgical prophylaxis and see if the process measure of compliance with your surgical prophylaxis is good, then you have won the battle. 80% you have won. in this AMSP if your real goal is to minimize AMR. The biggest misuse occurs in the outpatient because I am seeing patients privately, eyeball to eyeball. Nobody knows what I am using. In the surgical prophylaxis, yes, the dean will audit your surgical prophylaxis. So 40-80% you have solved your problem. But the remainder 20% we are focusing on the infection control in the hospital. Please understand that antimicrobial resistance to your strategy, CAHO strategy is to minimize AMR, is you have to work in these two areas and give impact on that. Now, outcome measure. Who is to do the outcome measure? Everybody speaks. I am not proud enough to say that my hospital, the MRSA in my hospital, I had a look at it. I am telling you now it is 3%. Which one? Surgical site infection. When I tell you my surgical site infection is 3% by following the ICMR guidelines or that of the CDC, etc. Yes, we know something that is when it is purulent and the etc. But we need to have this surveillance of resistance of the organism that is causing the patient's problem in your hospital. I am not a believer of using the data of CMC Vellore or that of any other corporate hospital in my hospital. So do you have a setup? Does the hospital have a setup to measure their outcome of having introduced AMSP? No lab, let me tell you, no lab in any hospital is focusing on the infection control aspects of their pathogen. I come to your hospital, there is no reason that I should be having MRSA on my skin surface. I may be a healthcare worker. But if I have a surgery and I get an MRSA, where did it come from? It has to come from the hospital or some poor infection control practice. So you have to measure that and say, in my hospital, the incidence of MRSA is very low. Prevalence of MRSA is high in every hospital, 40%, 50%. But are you causing MRSA infection in your hospital? Are you causing ESBL in your hospital? Yes, you are causing. How are you causing ESBL, E. coli or ESBL gram-negative infection? You're causing it by some vehicle. Maybe the vehicle is via my hands, maybe by hand washing, maybe the water that I use. So you must measure your outcome. If you don't measure it, it will just be talk, another talk, another talk. I have been talking on AMR from 1991 and I have not got anywhere except that I brought out a book, Management of Infectious Disease. Now the final thing is, what is it that you want to show? Sir, I do not have any death, or I have not had a prolonged hospitalization in my hospital as a result of a drug resistant or a drug resistant bug. You choose it. You choose your drug bug combination. You say you say E. coli or carbapenemase resistant drug bug combination. You choose it. And then say, I don't have MRSA incidents in my hospital. I don't have a KPC in my hospital. Who is bold enough to say? Who is taking the responsibility? Will the dean take, or the director of the hospital, or the CEO of the hospital take? Will you bring the Army, Navy and the Air Force if you have a bug like that? Will you close down your hospital? Let me tell you, I am a very strong believer that Acinetobacter is not a commensal in the body. Then where then is it coming from? It's coming from the environment. And where in the environment? Every day it's a very hardy organism to get rid of. Clean, clean, clean. I have that subject is a little separate thing. I have only 6 points to teach in infection control, and one of them is environmental cleaning in the ICU, where this bug is coming from. Anyway, so you must have your SSI rates, monitor any 1 or 2. You must have your the mortality rate as a result of infection. So having said this, let me state this. So you must have a good e-learning tool which you have created. You must conduct a survey of which hospital you want to evaluate and who is willing to participate with you. Then you should look at this quality improvement. And the fourth one is infection control. I don't want to get into that. Your lab must be strengthened. No microbiology lab. This is expensive. It is expensive to maintain a lab and to conduct antimicrobial and create an antibiogram. You need a minimum of 100 organisms collected over a period. Now, which lab has got 100 organisms of E. coli collected from the bloodstream, which is the best site, but don't have. So you manage with skin and soft tissue. E. coli as gram negatives have got no business to be there in the skin and soft tissue. You can get gram negatives in the urinary tract. So you have to, so you will get a lot of gram negatives from the urinary tract, and that will be the antibiogram of the hospital. So you must understand that lab needs to. Now, the last and the final point that I really want to say. So I've given you these 5 points which I looked at, e-learning tool. And the last thing is, being the dean of a medical college, it is imperative that every question paper in microbiology, every question paper in any discipline of surgery or medicine must have a question on infection control and or / antimicrobial stewardship. That is the only role, besides speaking with all of you, meeting all of you and speaking. That's, I think, in the remainder of the lifetime that I have, or the longevity that I have in academic medicine, I think my goal would be only to focus on medical colleges, so that the mainstream, the MBBS who's coming out, at least knows the spelling of AMSP, and if possible, knows the spelling of CAHO. Thank you so much. Thank you.
Thank you very much, sir. Now you know why we wanted you. Such a powerful talk, and I really, really appreciate you for all across to us, giving us a lot of ideas. Certainly, we take all those very seriously. That's part of it. And the second aspect of understanding the knowledge gap, certainly we'll require your help with that. We can jointly do it together as CAHO and deans of other institutes who could come forward and help us set it up. We will do a survey, do a study to understand the knowledge gap, and also set up indicators. Very definitely we can embark on that. And brilliant, sir, as usual. And thank you very much for taking your time and joining us.